This is the first OSCE question. Okay, a 65-year-old man undergoes transurethral resection of the prostate under spinal anesthesia. 2 weeks later, he presented to the clinic with weakness of right foot. On clinical examination, he has loss of sensation over the dorsum of the foot and motor power is only 3/5 for the dorsiflexion of the right foot. Which of the following investigations is most likely to confirm the diagnosis in this treatment? The options are MRI scan of the lumbar spine, fasting blood glucose, CT scan of the lumbar spine, electromyography.
Electromyography, sir.
Very good, excellent. Electromyography is the one. Why is the answer D is considered as the right answer?
It seems to be a peroneal nerve injury during the positioning.
Positioning, excellent. So nerve conduction studies include tests for both sensory and motor components. The likely cause of weakness of the foot here is compression of the common peroneal nerve by the lithotomy leg folder. Okay. So injury to common peroneal nerve causes foot drop and loss of sensation over the dorsum of the foot. So electromyography involves recording electrical activity in the muscle. It is useful to distinguish peripheral neuropathy from nerve root compression from more central cause like disc prolapse or other establishing the site of lesion. When is MRI or CT indicated?
When it is like a sciatica presentation, sir.
When there is a suspicion other than the lumbar disc prolapse causing nerve root compression or CT, MRI are useful. Why blood sugar is tested in this case?
So to rule out peripheral neuropathy, sir.
Neuropathy, spontaneous foot drop. Previously healthy patient may be due to metabolic cause such as diabetes mellitus. Okay. What is oximetry and what is cerebral oximetry?
Sir, oximetry, which measures the global oxygenation, cerebral oximetry, which measures the brain oxygen levels, tissue oximetry.
Focal.
Yeah. Oximetry refers to the measurement of hemoglobin oxygen saturation in blood or tissue. Okay, you can say pulse oximetry. So any oximetry is just a measurement of hemoglobin oxygen saturation. Whereas cerebral oximetry, the non-invasive bedside method for measuring tissue, that is cerebral hemoglobin oxygen saturation, is written as CO2. What is the difference between pulse oximetry and cerebral oximetry? This OSCE I have to prepare because the latest tutorial of the week, NCCR tutorial of the week by the WFSA, World Federation for Society of Anesthesiology, the article is on cerebral oximetry, which I received day before yesterday. After reading that, I thought I will include these questions.
Pulse oximetry, which measures the peripheral oxygenation saturation, cerebral oximetry, which measures the brain oxygen saturation.
Okay, but the arterial oxygen. So unlike pulse oximetry, which measures arterial blood oxygenation, cerebral oximetry assesses the entire oxygen without the need for a pulsatility of the tissue components. So it measures the arterial, venous, and capillary oxygen concentration in cerebral oximetry. Whereas pulse oximetry mainly picks up, which is equal to arterial blood oxygenation because it picks up the pulsatile component of the peripheral circulation. Okay. So cerebral oximetry evaluates all hemoglobin in the reflectance arc, including those with arterial, venous, and capillary. The resulting value biased towards large venous hemoglobin mass or venous weighted, because more of venous blood will be there than arterial blood. What is Harlequin syndrome and how is cerebral oximetry useful in this condition? This
presentation in babies where the skin
dry skin,
dry skin.
dry scaly skin appearance.
This is called differential oxygenation. Okay, differential perfusion phenomena known as Harlequin syndrome may occur when blood oxygenated by the extracorporeal oxygenator is delivered into the femoral artery, then up the aorta to perfuse the upper body and brain, and the deoxygenated blood expelled from the heart enters the ascending aorta. So this will be like this. Normally, deoxygenated blood enters the ascending aorta from the left ventricle, and when the patient is on extracorporeal oxygenation like ECMO, that oxygenated blood is pumped to the ascending aorta, the descending aorta in a retrograde fashion. So both the things meet here. So there is partial oxygenated blood going and partially deoxygenated blood going. So this is known as the Harlequin syndrome. It occurs when you use a extracorporeal oxygenation device. So cerebral oximetry can monitor cerebral perfusion to provide early warning of inadequate cerebral perfusion whenever there is a Harlequin syndrome. Because this initial part of the arch of the aorta, you have the common carotid artery going, which then divides into the innominate artery, which is going into divide into common carotid and subclavian. Then you have the left common carotid, left subclavian. So this will be perfused with the deoxygenated blood, which will also go to the cerebral cortex, and this partially mixed oxygen and deoxygenated blood will go to by the left common carotid. So in Harlequin syndrome, the cerebral oximetry will give you the cerebral perfusion depending upon the mixing that is happening. The role of cerebral oximetry in CPR. What is the role in CPR?
It measures the effective cardiopulmonary resistance.
Effectiveness of a cardiopulmonary. Its ability of cerebral oximetry to assess non-pulsatile flow is particularly beneficial in CPR. Because when you give CPR, the blood is merely pushed into the vascular compartment by your compressions. It doesn't happen like the normal pulsatile blood flow that is happening in a normal contracting heart. So the SCO2 is suggested to reflect the quality of CPR, predict the chance of spontaneous return of circulation, and provide early warnings of arrest and assist in neurological prognostication after return of spontaneous circulation. So all these advantages are there by measuring or monitoring the cerebral oximetry in CPR also. What procedure is shown in this model?
Thoracotomy.
VATS.
Video assisted thoracoscopy.
Video assisted.
Okay, VATS, very good. What types of surgeries can be done by this technique?
Pneumonectomy, esophagectomy, biopsy.
Lung, heart, and esophagus surgeries. You can classify them as lung, heart, or esophagus surgeries. What anesthetic technique is used for this procedure?
General anesthesia with double Newman tubes.
Very good. General anesthesia with deflation of the lung on the side to be operated. So how is it achieved, the deflation of the lung?
With the use of double
Double
Newman
Double
tube
Newman
or
can be achieved by the DLT.
Bronchial
Single Newman tube with bronchial blocker also can be used. How do the corrective steps to prevent hypoxia during one leg ventilation and normally for other surgeries where there is an open surgery differ during video assisted thoracoscopy? Here there are only keyholes that are made, not a big thoracotomy incision, unlike when you do the open surgery. So the hypoxemia produced by one lung ventilation What is the difference between open surgery and video assisted surgery?
The pneumo created during the VATS.
What are the steps in managing the hypoxemia in open surgery, one lung ventilation?
You'll administer 100%
100%
oxygen in case of
100% oxygen.
hypoxemia.
Just to suctioning using a separate suction for
We have seen that in last few some classes where I said 6 steps you have to remember. You remember that?
switch from 100% oxygen, suctioning, provide
Keep up to the non-ventilating
PEEP,
lung.
Keep to the
ventilated lung, and
CPAP to the
CPAP to the non-ventilating lung.
Or captainally remove the tube and go back to double lung ventilation. Okay, these are the common things that we do. But unlike open thoracotomy using one lung ventilation, CPAP to the non-dependent lung cannot be applied during that, as it will inflate the lung and hinder the view of the surgeon. Okay, so that is the only drawback. That is the only step that cannot be done. And 100% oxygen cannot be used for long in patients treated with bleomycin, as it may cause oxygen toxicity. And clamping of pulmonary artery is not done if pneumonectomy is not planned during VATS procedure. What are the complications of VATS surgery?
so hypoxia, atelectasis.
So dysarrhythmias like atrial fibrillation, SVT, bleeding, air leak, infection, respiratory failure, if pre-existing pulmonary dysfunction is present. So these are some of the common complications. What is being done here?
So, tracheal
Fiber
intubation
optic.
using fiber optic bronchoscope via
Which route?
nasal route.
So you can see the endotracheal tube being loaded in the bronchoscope, and he is passing it through the nose. So he is planning for a nasal intubation with a cupped endotracheal tube using the awake fiber optic nasal intubation under topical local anesthesia. What are the indications for this particular technique?
Any C-spine
Difficult
injuries?
Difficult airway, isthmus, mouth opening not good. Like neck morbid obesity, TM joint ankylosing, CA wormal cavity, or C-spine injury. Okay. What are the contraindications?
If the patient is unconscious,
Unstable patients who cannot tolerate the tube.
Any trauma
Patient refusal or unable to cooperate, bleeding in upper airway, allergy to LA drug, upper airway tumors. Okay, so these are the contraindications. Even in the unconscious patient, you can do it. There is no harm in putting a fibroscope in. What is the sensory nerve supply to the nose? You just mention the name of the nerves.
anterior ethmoidal nerves.
Oh, only one?
maxillary.
Greater palatine.
Nasociliary, nasopalatine, and ethmoidal nerve. 3 nerves you have to remember. Nasociliary, nasopalatine, ethmoidal. So 2 things coming with the naso. What are the techniques of anesthetizing the nasal cavity?
So by applying lignocaine jelly or using nasal packs, soap,
Vasoconstrictors.
Lignocaine with adrenaline.
Nasal drops like oxymetazoline can be given.
Oxymetazoline is reduced the
Vasoconstriction.
bleeding. It's not anesthetizing the cavity.
giving
So
nebulization.
Silocaine soaked blood jets or spray or nebulizer. What is Moffat's solution?
So it is a mixture of local anesthetics with
Which local anesthetic?
cocaine,
Yeah,
soda
asked
bicarb,
this question earlier. Bicarb and adrenaline. Okay, the mixture of adrenaline, sodium bicarbonate, and 10% cocaine. What is say-go technique?
spray as you go technique.
Spray as you go. Through the working channel of fiber optic scope called say-go technique.
Sugammadex reversal agents.
For aminosteroidal compounds.
It is a carton containing 10 vials of 2 ml of Sugammadex. So it is written here. So 10 vials are there. What category of drug is this?
Reversal agent, near reversal agent.
Cyclodextrin.
Novel drug.
The clinical. It belongs to
Cyclodextrin.
cyclodextrin. Gamma cyclodextrin. So it's called Sugammadex. What is the mode of action? The use of this drug.
Encapsulating the
Forms a
complex with the neuromuscular
Forms a
blocking
insoluble polymer.
and excrete them in
Does
the
it go and attach itself to the drug in the neuromuscular junction or in the plasma?
plasma.
Plasma level.
Encapsulation of the
encapsulation of
The
the
gradient is created so that the drug will detach from the neuromuscular junction. Okay, it does not go and directly act at the neuromuscular junction. It's a large donut-shaped molecule. It has a lipophilic core and hydrophilic periphery. It encapsulates rochronium molecules diffusing out of neuromuscular junction and forms a strong bond. It is used mainly to reverse neuromuscular blocking effects of acronym in children and adults. Since it has no interaction with acetylcholinesterase, there is no need to give glycopyrrolate or atropine along with this drug. Which other muscle relaxants can be reversed using this drug?
Vecuronium.
Vecuronium, pancuronium also. All aminosteroidal agents can be removed by this drug. What is the dose of Sugammadex for reversal of these agents?
It is based on TOF ratio.
TOF ratio or duration or the intensity of block. Okay.
if it is deep,
Dose
it
depends intensity of block, administration time, and the age of the patient. So moderate block can be reversed with 2 milligram per kg. Intense block is 4 milligram, and immediate use for 16 milligrams. What are the side effects of Sugammadex?
anaphylaxis and bad.
Clearly, common dry mouth, tachycardia, dizziness, and hypotension. What is the pathological condition shown here?
Ludwig's angina.
Ludwig's angina, very good. Bacterial infection involving the floor of the mouth and neck. You can see a swelling here, you can see the swelling here. What are the causes of this condition?
Bacterial
diabetes.
Bacterial infection is the ultimate pathology, but what other?
Diabetes mellitus.
Diabetes mellitus is a small child which we are showing. Dental infection, parapharyngeal abscess, fracture mandible, piercing injury, submandibular salivary gland stones. Okay, all these things. What are the signs and symptoms for this condition?
So airway obstruction, difficulty in phonation.
Difficulty in swallowing. Okay, swelling in the floor of the mouth lifts the tongue to cause difficulty in swallowing. Drooling of saliva, swelling in the submandibular region, which can cause airway compression, fever, chills, and pain because it's a bacterial infection. Okay. How is this condition treated?
drainage.
Incision and
Drainage.
Incision and
Antibiotic, analgesic, antipyretic, adequate hydration and nutrition. And if swelling does not reduce or cause airway compression, we need incision and drainage. What are the anesthetic challenges in this case?
difficult airways.
Anticipated difficult
Difficult airway.
Okay, this is a case of anticipated difficult airway due to restricted mouth opening, limited tongue mobility, and submental swelling. So, managed by either awake fiber optic or blind nasal intubation under topical LA. Rarely, tracheostomy may also be needed in these cases. What is this patient suffering from?
Lower back
Low
pain.
back pain.
Low back pain. Probably suffering from low back pain. Very good. What are the classification of low back pain? One of the common chronic pain conditions, isn't it? So pain like sometimes based on the duration. It is acute if symptoms are less than 6 weeks, and chronic when the symptoms are more than 3 months. Okay, so acute back pain, low back pain, or chronic low back pain. Acute less than 6 weeks of pain. If it is lasting more than 3 months, should be called chronic low back pain. Can also be classified as specific, and specific pathology, that is herniation of the disc, tumor, osteoporosis, inflammation, or fracture is present. And it can be non-specific when there is no identifiable cause is found. What is the mnemonic that can be used to assess the nature and severity of low back pain? OPQRST. Okay. O for onset, P for pattern, location and timing, Q for quality of pain, R for relieving or exacerbating factors, S for severity and systemic effects, and T for treatment taken. Okay. Onset, pattern, quality, relieving agent, severity, treatment. What is SLR? How is it done? What does positive SLR indicate?
Straight leg raise test.
Tests.
How is it done?
Patient will be in supine position.
Hmm.
They'll raise the lower limb without bending the knee,
Hmm.
and they'll check for radiating pain. Sir.
What is the angle? Degree.
More than 120.
The straight leg raising test. Patient lying supine, affected leg is raised without bending the knee. Positive test causes radicular pain between 30 to 70 degrees of elevation, indicating decreased mobility of the durometer. Okay. What is Carda equina syndrome? What are the manifestations and management of that condition?
Carda syndrome is compression of the lowest part of the spinal
Nerves.
nerves. Yes, sir.
Because from any lesion compressing the Carda equina nerve roots. Okay. And it can have bowel, bladder, sexual function involvement, features like back pain, lower limb weakness, and sensory deficit. The urgent decompression is the treatment to be done within 24 hours of onset if you diagnose Carda equina syndrome. Okay. Now, a 16-year-old girl presents after a seizure. History of present illness reveals that the seizure occurred with recovering after a wisdom tooth extraction under general anesthetic. Anesthetic administered include nitrous oxide, isoflurane, cisatracurium, and meperidine, that is pethidine. She developed a fever, tachycardia, hypotension, dyspnea before having the seizure. Her past medical history is significant for depression treated with monoamino oxidase inhibitor. He was intubated and given lorazepam. A urine drug screen is positive for methamphetamine. Which of the following is the likely diagnosis? The options are serotonin syndrome, neuroleptic malignant syndrome, malignant hyperthermia, seizure secondary to meperidine.
Serotonin syndromes.
Syndromes.
Serotonin syndrome. Any other option? They say they use meperidine. Patient is on monoamino oxidase inhibitor. Will you still go for serotonin syndrome?
Neuroleptic.
Sir, NMS, neuroleptic malignant syndrome.
There is a mention of meperidine here.
Seizures secondary to.
Seizure secondary to, because patient is on MO inhibitor, meperidine is contraindicated. It's a very important
Yes,
point.
sir.
Okay.
Yes, sir.
So what is serotonin syndrome and how is it caused?
So,
Due to drug interaction.
interaction
Which drug?
acts on MAO
inhibitors.
oxidase inhibitors.
All psychiatric drugs used like
Selective SSRIs.
this is a life-threatening condition that occurs when there is too much of serotonin in the body. So SSRIs, SNRIs, tricyclic antidepressants, MO inhibitors, which are all likely to cause this serotonin syndrome whenever the overdosage of these drugs happen. What are the differential diagnoses of serotonin syndrome?
Thyroid storm.
You have the answers
Malignant
here.
hyperthermia, neuroleptic malignancy.
Thyroid crisis, anticholinergic syndrome, malignant hyperthermia, neuroleptic malignant syndrome. Why pethidine is contraindicated in patients taking MO inhibitors? What other drugs are to be avoided if the patient is on MO inhibitors?
So, ephedrine, psychiatric drugs like SSRI, SNRI.
See, psychiatric patients are treated along with SSRI, MORI, and MO inhibitors. I'm asking. That means you say these drugs should not be combined. With severe depression or schizophrenia, they use all these drugs together. Okay, pethidine inhibits the serotonin reuptake, which can lead to serotonin syndrome. Okay, and MO inhibitors, they break down after the tramadol, methadone, dextromethorphan, and propoxyphene are other drugs to be avoided when the patient is on MO inhibitors. So, what is the function of MO enzyme? Not the inhibitor, MO enzyme in the body.
It metabolizes catecholamines.
Norepinephrine.
Breakdown of neurotransmitters like dopamine, noradrenaline, and serotonin. Okay. So when this enzyme is inhibited by these inhibitors, then these levels will go up. Dopamine, noradrenaline. That is why when there is a reaction with pethidine and epinephrine, this level of serotonin, noradrenaline, all these things go high up. The patient goes in for very severe hypertension initially, and then later on they will go for fever, tachycardia, hypotension, all these things.
TCI pumps.
Target control infusion.
Infusion pump of propofol.
This is a TIVA or TCA. Okay, using you can see this must be propofol, this must be maybe fentanyl or other drug, this may be a vaccine. So 3 syringes pumps used for TIVA or TCA. When you attach them one below the other, it is called stacking of the syringe pumps. What is the basis of TIVA?
So, avoiding inhalationals and
What is the basis of TIVA?
So creating a state of hypnosis.
with the help of plasma concentration.
Effector site concentration.
Effector site.
Intravenous
Effector site
administration of bolus and continuous infusion of anesthetic drugs to maintain a steady effector site concentration. That is the basis of TIVA. What are the advantages and disadvantages of TIVA? Here you can say you are avoiding inhalation agent, theatre pollution.
In-house.
Okay. Advantages are avoiding inhaled anesthetic agent, reduces OT pollution, decreases global warming, and useful in surgeries using laser. Disadvantages are expensive equipment needed, Concomitant depth of anesthesia monitoring also is a very important monitoring tool. Context sensitive half-life to be used to stop the drug. What are the specific indications for TIVA?
Malignant hyperthermia.
Very good.
Upper airway surgeries were
Tubeless upper airway surgeries. Okay, malignant hyperthermia is long QT syndrome, history of severe postoperative nausea in patients, tubeless thoracic or ENT surgeries, NORA, daycare surgeries, some neurosurgeries, myasthenia and neuromuscular disorders to avoid neuromuscular blocking drug, and anticipated difficult intubation and extubation cases. All these things is useful. What is this person likely to be suffering from?
Bronchial asthma, sir.
Bronchospasm. Okay, most probably suffering from bronchial asthma, bronchospasm due to. What is asthma and what are the characteristics of asthma?
Asthma is
Small airway disease.
reversible constriction of medium
Smaller
and
airway.
small size
Small
airways.
airway. It's an obstructive airway disease, which is a reversible obstruction of small airways. Okay, that is the feature. And it also has an inflammation and mucosal edema component. Increased mucus secretions will be there. So how is asthma classified according to National Heart, Lung and Blood Institute?
Mild, moderate, and
Mild,
Status
moderate and
status
mild
asthmatic.
intermittent, mild persistent, moderate persistent, and severe persistent. So three persistent categories: mild, moderate, and there's a category very intermittent, not very frequently. So if the attacks are less than 2 times a week, it is called intermittent. And when the patient wakes up less than 2 times in a month, it is also intermittent. And the PEF to PEFR ratio between attacks is more than 80% of predicted. When you do the pulmonary function test, FEV1 is more than 80%. And the persistent category, the mild one, at least once a day you get an attack, and you wake up at least more than 2 times in a month, and this 80% predicted FEV1 to PEF ratio is also there. Whereas in moderate persistent, there is a daily attack. Waking up is more than once a week, and the PEF and the FEV1 ratio also start decreasing. Severe, continuously present, frequent wake up, and PEF-F1 ratio is less than 60%. So this is the classification by National Heart, Lung and Blood Institute. How is asthma treated according to the above classification? So this classification is mainly to decide what are the drugs to be used and how to be used.
Initially, they'll give inhalational steroids for mild
Bronchodilators. From mild.
Ipratropium bromide.
Short acting beta 2 agonist for the intermittent group. Okay, only beta 2 agonist, no steroids. Whereas once it becomes persistent with mild, moderate, severe category, mild persistent beta 2 agonist plus inhaled steroids or leukotriene antagonist, and moderate persistent medium dose inhaled steroid, long acting beta 2 agonist, and severe persistent high dose of inhaled steroid plus long acting B2 agonist and oral steroids also. 62-year-old man with coronary artery disease, emphysema, undergoes Whipple's procedure for CA pancreas. He is being ventilated postoperatively. Suddenly develops hypotension with a BP of 60/30, the tachycardia of 130. What are the causes of postoperative hypotension?
So it is a major surgery. So secondary to cytokine storm.
Hypovolemia.
blood
Hypovolemia.
loss.
You must know how to classify the etiology of hypotension post-op period. Okay. And this patient has coronary artery disease, he has a lung disease, everything is present. So that also has to be taken into consideration. So
UTMI.
decrease preload, decrease in blood volume. It may be because of inadequate fluid or post-op bleeding or third stage loss or obstruction of venous return like cardiac tamponade, tension pneumothorax because of ICP and fluid. Decrease contractility because of the residual anesthetic drugs, myocardial ischemia, infarction, electrolyte disturbance, dyspnea, and hypothermia. Decrease in hyperload. So these three, preload, contractility, hyperload, these three things have to be first thought of. Residual effects of vasodilators, anaphylaxis, and sepsis. And rate disturbance, extreme bradycardia or tachycardia. And so these are all the cardiac factors that we have to think of. Now, define shock. What are the types of shock?
Hypoperfusion of the
Decreased oxygen supply to the
Tissues.
tissues, sir.
That is the correct term. Shock is defined as failure to meet the tissue oxygen requirement. Okay, that may be because of the defect in pumping or lack of hemoglobin or vasculature. So ultimately, the tissues don't receive oxygen for aerobic respiration. They resort to anaerobic respiration. So the types are cardiogenic, obstructive, hypovolemic, and distributive. How would you treat each and every condition? Like that is these patients who has developed hypotension and tachycardia, how to treat this patient?
So for cardiogenic shock, after confirming the diagnosis, first line of management is inotropes, sir.
dopamine or dobutamine.
For
Hypovolemic
hypovolemic
do
shock is resuscitation with
Fluids.
either if it is dehydration fluid or blood should be replaced by blood, sir. For distributive shocks, it is the first drug of choice is vasopressors. Sir.
So first step is to identify the type of shock present in this patient. Here it is with regard to the clinical scenario that has been given. The first step is to identify the type of shock. Since it has happened in the post-op time, rule out hypovolemic shock due to bleeding or third stage loss, number one. Next is to rule out poor myocardial contractility since the patient has CAD, urgent EKG and bedside echo and biomarkers may help. Then lastly, rule out distributive and obstructive causes as the patient has emphysema. And invasive monitoring, central venous pressure, PA pressure monitoring, cardiac support and fluid resuscitation may all be needed in this case. What is shown here?
cervical plexus.
Cervical.
Excellent. Cervical plexus block found by C2, C3 and C4. Okay. How is the cervical plexus classified anatomically?
Superficial and deep cervical.
Superficial and deep. Very good. Excellent. What are the branches of cervical plexus? Lesser occipital, greater auricular, cutaneous branch in the rectal region. What are the indications for superficial cervical plexus block?
So shoulder surgeries, thyroid surgeries, clavicle
Surgeries on the anterolateral part of the neck like carotid endarterectomy, unilateral thyroid gland or lymph node excision. What is the technique of blocking the superficial cervical plexus?
landmark technique and ultrasound guided blocking, sir. Landmark technique, it is the midpoint of posterior border of sternocleidomastoid we have to inject 5 to 10 ml of local anesthetic in the fan shaped manner.
So patient position, head position, all that to be sold. Patient
Yes,
lying
sir.
supine, head turned to the opposite side of the block. Mark the lateral border of the sternocleidomastoid mastoid. Point midway between the tip of the mastoid process to medial end of clavicle is the insertion point. External jugular vein usually crosses near this point. 15 to 20 ml of LA drug is needed. So this is how the drug is given. Okay. What are the complications of this block?
Horner syndrome.
Injury to
Mainly
the
vascular injury, injection causing LA toxicity, nerve injury, and pneumothorax. How deep cervical block differs from this superficial cervical block?
From C6,
Be compared to interscalene block or as a paravertebral block, because you give it very close to the transverse process of the vertebra. Okay, so it is much more deeper compared to the superficial. So it can be almost like a interscalene or a paravertebral block. What is depicted in this picture? Pharmacology question. Chirality of the molecules depicts the chirality of the. What is meant by chirality or chirality?
mirror image of
Derived from Greek word having handedness. This is a type of stereoisomerism. Okay, the type of stereoisomerism. There are many drugs which exist as right or left-handed form of the mirror, but cannot be superimposed. They are called enantiomers, substances of opposite shape. And this form of stereoisomerism is dependent on one or more chiral centers. Chiral center is a carbon atom with 4 groups attached. So this is the carbon has got 4 groups attached to that. The other name for the enantiomer is optical isomer. This has the ability to rotate polarized light. What are the different nomenclatures used to describe these chiral substances?
levo, dextro.
Dextro, levo, very commonly all of you know that. Then, so based on optical activity, they can be dextro if they rotate the light to the right, levo if they rotate the light to the left. Based on relation to the configuration of another molecule, that is glutaraldehyde is D and L, which is not used in use anymore. The third other common method is based on the sequence of attachment of atoms or groups to the central carbon. So this is a central carbon. If the groups that are attached are arranged in the largest to smallest group in clockwise manner, it is called R, meaning rectus. And if they are arranged largest to the smallest in anti-clockwise direction, it is called S, meaning sinister. So that is why you have the single. If both these R and S are present in the same molecule, what is it called? So, for example, ketamine, if it is containing both R and S components,
Enantiomers.
called a racemic mixture. Okay? Any drug containing both the R group and S group, it is called a racemic mixture. When you isolate, that is why nowadays we have levobupivacaine. Bupivacaine is a mixture of both R and S form. So we separate that levo component, which is less cardiotoxic. Similarly, we have R-ketamine, which is coming up in the market, which has less emergence delirium. So like that, we can separate the component If both are present in the drug, it is a racemic mixture. This is a very common question. You have to know the answer for that. Okay? So this is the way of arrangement. This is central carbon. If all the largest to the smallest is present in the anti-clockwise, it is sinister. It is present in the clockwise direction, it is rectus. Okay? So how do you write a levobupivacaine enantiomer? We want to write symbolically. It has to be written like S dash minus. Okay, this is the levo symbol, and this is the sinister because it has a anti-clockwise arrangement. So that is the way levobupivacaine has to be written as a symbol. Mention the chemical properties of this drug, which you are using very commonly. Which group or chemical it belongs to?
Phencyclidine derivative.
Phencyclidine. Yes, it's a cyclohexanone derivative of phencyclidine. Cyclohexanone derivative of phencyclidine. It's a water-soluble compound presented in concentration of 10, 50, and 100 milligrams per ml, with or without preservative, with a pH of 3.5 to 7.5. And it has a racemic mixture of two enantiomers, both dextro and levo or S and R forms. Okay, and that is why nowadays, as I told you, R-ketamine is becoming more popular. Describe the mechanism of action. How does it produce analgesia?
NMDA receptor antagonism.
NMDA receptor antagonism, very good. So what happens exactly when it goes and blocks the NMDA receptor? What happens? This is an NMDA receptor antagonist. Agreed. Okay. NMDA receptor is a L-glutamate receptor in the CNS with an excitatory action. So ketamine binds to the cation channel in the receptor to block its effect. That is, calcium entry is prevented. Okay. So ketamine also acts on the opiate receptors by partial antagonism at mu and agonist at kappa receptors and delta receptors, and that is the mode of producing analgesia. So this produces what is called dissociative anesthesia. The excitation is blocked. Enumerate the uses of ketamine in anesthesia.
IV induction agent
Very good.
and propofol pain-free agent
Propofol pain-free agent.
for pre-treatment with propofol pain-free.
Treatment to prevent propofol-induced pain injection. Okay. So can be used as an induction agent for both adults and children. Okay, number one. Used as an analgesic in field anesthesia. Whenever you go to a massive casualty or an accident site, you give pain relief for the victims there, you can use it. Can be used as a bronchodilator in refractory asthma. Can be used for chronic pain treatment for post-op analgesia, especially in opioid addict patients. Used as shadow analgesia during local or regional anesthesia. What are the routes of administration of ketamine?
Intravenous, intramuscular.
Intrathecal.
Intrathecal, where preservative-free ketamine can be given intrathecal. Very good. Then nasal, buccal, oral, all the routes have been there. IV, IM, oral, nasal, intrathecal, epidural, every route has been administered. Okay, except rectal, all the other routes are there. What is the clinical sign of onset of action in children? Supposing give ketamine to a child, IM. How do you know the drug has started acting?
The respiration.
Horizontal nystagmus will be there. Okay? If you look at the eye of the child, it will have horizontal nystagmus. which happens both during onset of action as well as during recovery. Okay, so it's a short duration action. So if you give it IM, it will act for 15 to 20 minutes, both during onset as well as the time when the child recovers from the effect of the drug. We will have horizontal stagnancy. How much is low dose ketamine and its use? How much?
So
What is the dose?
labor analgesia and also
What is the low? How much is the dose for low to be called as a low dose?
0.25 to 0.5 mg.
100 to 200 mics per kg. Okay, 0.1 to 0.2 for short duration pain relief. You can give this anywhere whenever you want to use it. Okay, what is the time? 8:15. The last one. What is shown here?
so cylinders,
Oxygen.
Of
various
color
types,
coding.
color coded.
Nitrous oxide.
Same size or different size?
Different size.
We have two F-type and two
Yes,
G-type
definitely.
cylinders of oxygen and nitrous oxide. What are the parts of the cylinder?
Body,
Neck,
neck,
shoulder,
Body,
body.
shoulder, and valve. Very good. It is wood metal, and where is it used and why?
Heat resistance.
It's heat resistant or heat susceptible? Melts.
Heat
Heat
susceptible on
susceptible.
at higher temperature it melts and
See, this is the valve portion. Okay, this is the metal portion, which will be screwed into this neck portion. Okay, so it is just rotated and fixed into the groove. So the valve portion is screwed to the neck of the cylinder, and wood metal is used during that time to seal any leaks. This metal will melt when cylinder is exposed to intense heat and prevent explosion by allowing gas to leak out. Okay, that's the purpose of this wood metal. What is shown in this picture? See, this is the screw thread which will go into the neck portion for fitting into the. So this is the left is what is called the bullnose valve. Okay. The right is called the hand wheel valve. It's a wheel already present. So what is the advantage of hand wheel valve?
without the use of equipment we can
Correct. For this you need a separate key which will be fitted into that and rotated. Okay. So it does not require the extra equipment like the wrench to open it. What is seen in this picture?
cylinder with a pressure gauge.
Pressure gauge fitted. And this is a portable cylinder with a built-in pressure regulator, mainly for home use, is called integral valve. What is shown here and how does it work?
So heliox, it is a mixture of helium and oxygen. So
What is the percentage?
70 and 30.
21 and 79, containing 21% oxygen, 79% helium mixture. Helium is low density, reduces the resistance to flow, and converts turbulent flow into laminar flow. So where do you use it? Helium.
So during airway obstruction,
For airway obstruction mainly. Okay, when the flow is turbulent. Okay.
so
So shall we stop here?
Yes, sir.